Good morning, everyone. Today I will be presenting on care of potential organ donor, focusing on clinical, legal, and ethical aspects in Indian context. So, in the ICU, the intensivist plays a central role in managing a potential organ donors. First is the early recognition. We must identify the patients with signs of brainstem death and consider donor suitability at the right time. And next comes the hemodynamic stability. Maintaining stable blood pressure and perfusion is crucial to preserve the organ quality. Then legal certification. Brain death must be confirmed strictly as per the established criteria. We also have important role in family guidance where we communicate with and support families during the end of life decisions. Finally, the protocol management. We ensure all hospital protocols are followed and coordinate effectively with transplant teams. And brain death include coma, absence of brainstem reflexes, and apnea. So overall, the intensivist is the key link between the identification, maintenance, and successful organ donation. When we look at the global organ donation rates, there is a significant variation. Countries like Spain has the highest rates, around 32 per million population, followed by US and UK. In India, the rate is still very low, that is 0.5 to 0.8 per million. The major reason is the difference in the system and the policies they followed. In Spain, it is an opt-out system where every individual is presumed as an organ donor unless they opt out. So, but in India, it is an opt-in system. So it requires a proactive individual registration for organ donation. In India, organ donation is not a uniform across the states. It is there is a clearly difference between the states is there, and Tamil Nadu has consistently shows the best performance, mainly due to strong government support and organized system like Transplant, which is the Transplant Authority of Tamil Nadu. And Maharashtra has improved significantly with better policy, and Kerala shows the steady growth with combined efforts of public and private. Telangana has rapidly adopted a transparent allocation systems, which is encouraging. In India, organ transplant is supported by the structured national framework. At the top is the Ministry of Health and Family Welfare, which provides overall guidance. Under this, we have a NOTO, National Organ and Tissue Transplant Organization. It acts as a central coordinating body and maintains the national registry. Below the NATO, there are regional level ROTOs, which cover the different zones like north, south, east, west, and northeast. Further down, there are state level organizations. So, the structure network ensures a coordination, transparency, and equitable organ allocation across the country. So now coming to the legal evaluation of the organ transplantation in India, the journey started in 1992 with the introduction of Transplantation of Human Organs Bill. In 94, the THOA Act was officially enacted, which laid to the foundation for organ transplantation in India. Later in 1995, rules were established mainly focusing on brain death certification, which is crucial for organ donation. Between 2010 and 2012, the National Organ Transplant Program was launched, which eventually led to the formation of NATO. Currently, we follow TOTA, which is the updated version of this act. The most important point here is brainstem death is legally considered as a death, which allows organ donation to proceed. So, a potential organ donor is not just any critical ill patient. We need to fulfill the specific criteria. First, there should be a catastrophic and irreversible brain injury. And second, this should be supported by radiological evidence. And third, we must ensure absence of confounders like drugs, metabolic disturbances, or hypothermia. And finally, all preconditions must met and stabilized before testing. An important legal point here is once the brainstem death is declared under TOTA, the patient is legally considered dead and donor protocols can be initiated. So, brain death diagnosis is based on a strict clinical trial. First, irreversible coma. The patient must be completely unresponsive and that should be clearly known and cause should be clearly known. Second, the absence of brainstem reflexes. This includes pupillary, corneal, oculocephalic, caloric, gag, cough reflexes. And the third is positive apnea test, which confirms that patient cannot breathe even when the carbon dioxide levels are increased. Very importantly, all these findings must be accessed only after ruling out the confounding factors. So, to diagnose a brain death, we must have a valid irreversible cause. One of the major category is traumatic causes like road traffic accidents, any industrial injuries, or gunshot wounds. Another important category is vascular causes like spontaneous intracranial hemorrhage. These conditions lead to severe irreversible brain damage. So, identifying the cause is important because brain death cannot be declared without a clear etiology. So other causes include hypoxia or anoxia, where the brain is deprived of oxygen. Examples like cardiac arrest, hanging, drowning, and next are the toxic and metabolic causes such as drug overdose, asphyxiation, and carbon monoxide poisoning. So we also have a primary neurological diseases like brain tumors, meningitis, and it is important to note that these conditions should not act as a confounders at the time of testing, like these metabolic and toxic. So before diagnosing the brain death, it is absolutely essential to rule out the confounding factors, these conditions that can mimic the brain death but are potentially reversible. First is the hemodynamic instability. If the patient is in shock or hypotension, assessment is unreliable. And second is temperature. Hypothermia, mainly the core temperature below 32 degrees, can suppress the brain activity. And third one is metabolic disturbances like severe hyponatremia, hypophosphatemia. Unless these are corrected, we should not proceed to the brain death testing. And in addition to the physiological factors, we must also consider the neurological and pharmacological confounders also. Neurological exceptions like neurotoxic snake bite, brainstem encephalitis, GBS, and severe encephalopathy can mimic the brain death. Next, pharmacological causes like drugs, anesthetic agents, sedatives, neuromuscular blockers, alcohol, all these can be act as a pharmacological confounders. So, before performing the clinical test, certain prerequisites must be confirmed. First, there should be established cause of the coma, such as a major head injury or intracranial hemorrhage. Second, there should be a neuroimaging confirmation like CT or MRI, which supports the diagnosis. Third, we should rule out the confounding factors. So, we must exclude the pharmacological causes as we discussed earlier. If overdose is suspected, we should wait for at least 5 drug half-lives or confirm with the drug levels. Also, body temperature must be maintained above 34 degrees Celsius before testing. The apnea test is the final and most important clinical test for confirming the brainstem death. It is considered as reliable and standard method in clinical practice. The principle is simple. We check whether the patient has any respiratory drive. During the test, carbon dioxide levels are allowed to rise. So normally this should stimulate the breathing. If the patient do not initiate any breathing effort despite of high carbon dioxide, this test is considered to be positive. So if the patient does not initiate any breathing efforts despite of high COT, it is positive apnea test. So once the brain death is suspected, the certification must be done strictly as per the law. In India, TOTA mandates a panel of 4 doctors. This includes a treating physician, a doctor in charge of the hospital, an independent medical specialist, and a neurologist or neurosurgeon. In their absence, a trained physician or anesthetist can also be there, can also be present. This ensures that diagnosis is objective, unbiased, and legally valid. So, brain death certification is done in a structured and time-bound manner. First, the panel conducts an initial assessment, which includes a clinical examination and apnea test. Then, there is a mandatory of 6 hours gap. After that, same panel performs a second independent assessment. If both the assessment confirms the brain death, documentation is completed using a Form 10 as per the TOTA guidelines. So here the key point is 2 assessments with 6 hours gap and proper documentation. Family communication is one of the most sensitive part of this process. Importantly, we must separate declaration of brain death from the organ donation request. First, the physician ICU physician role, that a senior doctor should clearly and compassionately explain what brain death means, how it differs from coma, and address the family's emotional concerns only after brain death is formally emotional concerns, and only after that brain death is formally declared, and then the transplant coordinator approaches the family. They will discuss about the organ donation, ensuring the cultural sensitivity and transparency, and these will improve the consent rates. So, timing and communication approach are extremely important. In India, the next of kin consent is mandatory. Even if the patient had previously signed for organ donation, uh, but the next of kin is mandatory. Consent is mandatory. Usually, the hierarchy includes first the spouse, and next adult children, and next parents. Consent must be followed a documentation using a Form 8 under TOTA guidelines. Also, in medical legal cases, if any medical legal cases like trauma and accidents, police intimation is mandatory because mandatory before proceeding. So, proper consent and legal clearance is essential for organ retrieval. To summarize, first in phase 1, identification of the potential donor is important, and next preconditioning to stabilize the patient and maintain hemodynamics, confirm imaging, and rule out confounders, and third clinical diagnosis like brain death is confirmed using a trial like coma, absent reflexes, apnea test, and fourth the legal certification, panel of 4 doctors 6 hours apart. And fifth is consent and handover. So now moving to another important aspect like medical suitability and contraindications, along with detailed clinical testing of the brain death. So in phase 1, we assess whether the patient is medically suitable for organ donation. There are absolute contraindications where we should not proceed at all. These include HIV infection, uncontrolled systemic infections like sepsis, rabies, and active malignancy with a high metastatic potential, prion diseases like CJD, and untreated TB, invasive fungal infections, unexplained encephalitis. Then we have a relative contraindications where careful evaluation is needed. These include advanced age, diabetes, hypertension, marginal organ function, prolonged hypotension, or high vasopressor support, hepatitis B or C positivity, past malignancy in remission, and obesity. So, decision making should be individualized. Before brain death testing, we must confirm a certain prerequisites. First, the patient should be in deep coma with no response to the pain stimuli. However, spinal reflexes can still present. Brainstem reflexes should be absent for a sufficient duration, usually at least 4 hours. Painful stimuli should be applied through a cranial nerve pathways, not peripheral stimulation. So the common cranial nerve pathways where we should give painful stimulus are supraorbital notch, trapezius squeeze, temporomandibular joint, sternal notch. So this ensures that we are truly testing a brainstem function. So, brainstem function is assessed through a series of reflexes involving the cranial nerves. First, pupillary reflex. No response to light indicates the brainstem dysfunction. Corneal reflex. No blinking when the cornea is touched. Facial response. No reaction to the facial stimulation. Oculocephalic reflex or doll's eye movement. Eyes remain fixed during the head rotation. But this this should be done only after ruling out the cervical spine injury. And oculovestibular reflex, no eye movement after cold saline installation in the ear. Finally, the gag and cough reflexes. Absence indicates failure of lower brainstem functions. So, absence of all these reflexes confirm a loss of brainstem activity. So, apnea test requires a strict prerequisite before performing it. This includes a core temperature should be 36.5 degrees or more. Systolic BP should be at least 100 mmHg. No sedatives. Adequate oxygenation. PaO2 should be above 200 on 100% oxygen. Baseline PCO2 should be normal. A positive apnea test is defined by no spontaneous breaths even after PCO2 raises above 60 mmHg or 20 mmHg above baseline. This confirms that complete absence of respiratory drive. So, this is the procedure of apnea test. Apnea test is performed in this stepwise and controlled manner. First, we will pre-oxygenate with 100% oxygen for 10 to 15 minutes, followed by a baseline ABG. Second, continuous monitoring using ECG, pulse oximeter, blood pressure. And third, fully expose the chest and abdomen to detect any respiratory efforts. Next, disconnect the ventilator while providing an oxygen via catheter or TPs or CPAP. Then observe carefully for 8 to 10 minutes for any chest or abdominal movement. Finally, repeat ABG to check the CO2 raise. If there is any respiratory effort, PCO2 criteria, if there is no respiratory effort and PCO2 criteria met, then the test is positive. Normally, apnea test is generally safe, but it can have some complications. It can have some complications like hypotension is seen in 7 to 9%, hypoxia around 5%. Rare complications include arrhythmia and cardiac arrest. So, some troubleshooting. If the blood pressure drops, we manage with fluids, inotropes, and vasopressors. If systolic BP falls below 90, then the test should be aborted and repeated later. So, if oxygen saturation goes below 85, the test should be stopped immediately, and we can retry after using CPAP or TPs and oxygen to improve TPs to improve the oxygenation. So, certification rules slightly vary from country to country. In India, testing must be repeated after 6 hours and confirmed by 4 panel of doctors, as we discussed earlier. And the time of death is legally taken as a time when the second apnea test is positive. Ancillary tests are not routinely required, but are recommended in specific situations when there is a doubt in clinical diagnosis, when the cause of brain injury is unclear, when apnea test cannot be performed or repeatedly aborted. And these guidelines were supported by ASCCM recommendations. When ancillary test is required, several modalities can be used. EEG shows a isoelectric or flat tracing. Cerebral angiography is a gold standard, and it tells us the absence of cerebral blood flow. And CT angiography can also be tried. And transcranial Doppler, it shows the absent or reverberating flow. So brain that occurs due to a progressive downward ischemic cascade. First, severe brain injury increases the intracranial pressure. When ICP exceeds the MAP, the cerebral perfusion stops. This will lead to global ischemia. This progresses in stages. First, the ischemia spreads downward. Then pons ischemia will lead to Cushing's response, followed by medullary ischemia, leading to sympathetic storm, followed by spinal cord ischemia. This results in vasodilation and hypotension. Finally, there will be loss of autonomic function, which includes hormonal failure. So, this flowchart explains the hemodynamic instability seen in the brainstem death patients. So in brain death, there is a characteristic biphasic hemodynamic response. Initially, due to the brainstem ischemia, there will be a Cushing's reflex and a massive catecholamine surge. So it is called a sympathetic storm. So due to this sympathetic storm, there will be a severe hypertension, tachycardia, intense vasoconstriction in the initial phases. In the later phases, as ischemia progresses, catecholamine stores become depleted. This will lead to vasoplegia and profound hypotension. This hypotension phase is very dangerous because it directly compromises the organ perfusion and transplant viability. So, sympathetic storm initially stresses the heart, causing arrhythmias, myocardial injury, and even stress cardiomyopathy. Later, vasoplegia reduces the preload, afterload, and contractility, resulting in reduced cardiac output and decreased oxygen delivery. At the same time, respiratory complication can also occur as a pulmonary edema, which can be either neurogenic or cardiogenic, along with the ventilator associated lung injury. And all these combined effects can hamper the oxygen delivery and compromise the donor organs. So brain death also causes profound endocrine and metabolic disturbances. There is a vasopressin depletion leading to diabetes insipidus, along with hyperglycemia and thyroid dysfunction. Electrolyte imbalance such as hypernatremia, hypokalemia, and hypomagnesemia are common, and these can precipitate arrhythmias also. Additionally, there is a loss of hypothalamic control, causes failure of thermoregulation, leading to hypothermia. All these factors further worsen the organ perfusion and viability. The key concept is that brain death is not a single static event, it is a dynamic physiological collapse. So, the same process that can lead to so the key concept here is it is a dynamic physiological collapse. So therefore our goal in ICU is to replace this lost autonomic function artificially. We do this by maintaining the hemodynamics with fluids and vasopressors, optimizing the oxygen delivery, controlling the temperature, correcting endocrine and electrolyte disturbances. This helps to preserve the optimal organ viability. So these all we have discussed. And next, after brain death certification, we will focus the focus of care completely shifts. We move from end organ of the life care to active organ preservation. This requires goal directed donor management, where intensive care so this requires a goal directed donor management where intensive care is continued with invasive monitoring, op- optimize the perfusion, oxygenation, and organ function. Here, our aim is not to just maintaining the life, but our aim should be in preserving the organ viability for transplantation. So, here there is a VIPP framework. V means ventilation. We should optimize the oxygenation and lung protection. Infusions with adequate fluid resuscitation for the preload. P for pumping. Use vasopressors and inotropes to maintain the circulation. Pharmacological and hormone replacement therapy should be given, and the target hemodynamics should be systolic BP more than 100 mmHg, and MAP should be more than 75. The goal is to ensure the adequate organ perfusion and oxygen delivery. So all the potential donors require a continuous baseline monitoring, ECG for arrhythmias, and blood pressure by preferably invasive blood pressure monitoring, and pulse oximeter and core temperature monitoring. Hourly urine output monitoring should be done. Target should be 1 to 3 ml per kg per hour. And CVP is not reliable, so we rely more on the dynamic assessment methods. Bedside echocardiography is a key tool in donor management. It helps in assessing the volume status via IVC distensibility, cardiac output using velocity time integral, and overall cardiac function. It should and to assess the overall cardiac function, echo can be used. It also helps to identify the causes of instability like cardiac dysfunction or hypovolemia. In unstable donors, advanced monitoring is required. So, these include a persistent metabolic acidosis, signs of poor perfusion, suspected cardiac dysfunction. Advanced tools like pulmonary artery catheter and cardiac output monitoring systems can be used. And key targets here are cardiac index should be more than 2.5 liter per minute per meter square, and SCVO2 more than 70%. Pulse pressure variations can be used for assessing the fluid responsiveness. So fluid management in the organ donors is it is a delicate balance because the primary choice is balanced crystalloids like RL and the plasmolite. On one side, adequate fluids are essential for renal perfusion and maintaining intravascular volume and correcting the hypernatremia. This improves the kidney and liver graft outcomes. On the other side, excess fluid can lead to pulmonary edema, right heart strain, compromising the lung donation. So, our goal is to maintain the euvolemia, not to overload. Fluid choice is crucial in donor care. We should avoid the hydroxyethyl starch as it causes a renal injury and graft dysfunction. Gelatin fluids are not recommended due to lack of evidence. Hypertonic saline may have benefits but require strict sodium monitoring. Risk of worsening hypernatremia is there, and albumin can be used selectively, mainly to reduce the pulmonary edema, but evidence is limited. So, balanced crystalloids remain the first line. When vasopressors are required, norepinephrine and vasopressin are the preferred agents. Vasopressin is particularly useful because it can treat vasoplasia. It also corrects the diabetes insipidus. However, high dose norepinephrine should be avoided because it impairs the cardiac contractility, mainly the right ventricular function. So it can worsen the post-transplant cardiac outcomes. So high dose NORAD should be avoided. Next, brain that causes depletion of loss of brain that causes complete loss of hypothalamic and pituitary function. This can lead to hormonal failure, severe metabolic and fluid dysregulation, and hemodynamic instability. This so one of the most important endocrine complication is DI due to vasopressin deficiency. Features like polyuria and hypernatremia can be seen. It can be treated with vasopressin in infusion, 0.5 to 2.4 desmopressin. If untreated, it can lead to hypovolemia, electrolyte imbalance, and reduced organ perfusion. And brain death can also lead to temperature regulation loss. It can initially cause hyperthermia, later progressive hyponatremia, hypothermia. Hypothermia can be dangerous because it can cause a coagulopathy, worsen the metabolic acidosis, leads to arrhythmias, and reduce the oxygen delivery by shifting left shift of the oxygen dissociation curve. So active temperature monitoring is essential. Brain death also triggers a systemic inflammatory storm due to ischemia reperfusion injury. Cytokines like IL-6 increase, and it is associated with poor graft outcomes. We will manage with corticosteroids like a methylprednisolone 15 mg per kg. This reduces the inflammation and stabilizes the hemodynamics. For glycemic control, in brain death, there will be decrease in insulin and increase in insulin resistance, and there will be stress hyperglycemia. Hyperglycemia can damage the pancreatic cells. So target glucose is 120 to 180. So hormone replacement improves the cardiac output and hemodynamic stability. So we will replace the T4 with the bolus dose of 20 mics and infusion of 10 mics per mm, hour, and the T3 bolus of 4 mics and the infusion of 3 mics per hour. So no, I didn't. So this uh, United Network of Organ Sharing, this organization promotes this combined hormone protocol like giving vasopressin, corticosteroids, thyroid hormone, and insulin. This improves the multi-organ donation outcomes. So hypernatremia, correction of hypernatremia requires an aggressive fluid replacement. However, excess fluids can lead to pulmonary edema, and inadequate fluid lead to persistent hypernatremia. So management should depend on balancing both. So in hypothermia is very common and dangerous. This happens because of loss of thermoregulation, and there won't be any shivering mechanism, and there is also a peripheral vasodilation and a reduced metabolic rate, all of which contributes to the heat loss. If hypothermia progresses, it can lead to serious complications. It worsens the metabolic acidosis, coagulopathy, and increase the risk of arrhythmias. So hyperglycemia is very common in the brain death patients. So target glucose is 120 to 180, and maintain the sodium less than 155, and serum potassium should be maintained between 4 to 5. So hypernatremia is associated with decreased liver graft survival, and lung protection is very important to preserve the lung viability. So the main principle is to maintain to principle the ventilator induced lung injury. So we use a low tidal volumes and plateau pressures less than 30, and PEEP more than or equal to 5, and minimal FiO2. So PO2 targets should be more than 100 and SPO2 more than 95. PCO2 should be maintained between 35 to 40, and pH between 7.3 to 7.45. So in brain dead donor, there will be a compromise of immune system. So there can be infections. Severe brain injury can lead to loss of cellular immunity. This is followed by hemodynamic instability and a bacterial translocation from gut into the bloodstream. All these factors can and many invasive lines will be there. All these factors can increase the risk of infections. So sepsis is not an absolute contraindication for organ donation. If the donor has a bacteremia or a sepsis, organs can still used provided when appropriate antibiotic therapy is given. The donor should be received targeted antibiotics for at least 48 hours before organ retrieval. After transplantation, the recipient should continue antibiotics for about 7 to 10 days. So positive blood cultures Seen around partial blood cultures can be seen around 20% of the donors, mainly in the older patients. And when coming to nutrition, enteral nutrition play a key role. It helps in maintaining the gut integrity and prevent the bacterial translocation, which is a major source of infection. And so enteral nutrition should be maintained, and strict hygiene should be maintained. Routine hand hygiene should be maintained, and prophylaxis with broad spectrum antibiotic should be administered strictly as per the hospital antibiotic stewardship protocols. So here, eye care should be taken, and we should place the nasogastric tube to prevent the aspiration, and stress ulcer prophylaxis should be given, and elevate the bed head of the bed to 30 to 45 degrees to prevent the risk of aspiration, and routine bronchial toileting techniques should be done and clear the secretions to improve the success of lung donation. And vascular lines, arterial line and central venous lines should be taken on the upper limbs because during organ retrieval, these can hamper the tracing of the readings. So, thermoregulation should be maintained, catheter care and DVT prophylaxis should be maintained. So, this is the rule of 100. Systolic BP should be more than 100. PO2 should be more than 100, and urine output should be more than 100 ml per hour, and HB should be more than 10, and the blood glucose should be more than 100. So documentation is the legal backbone of the organ system, organ donation. It must be complete, accurate, and strictly followed. Standard formats are provided by the NOTO, and all the process must follow TOTA guidelines. Any error in documentation can compromise the entire donation program. The documentation is a shared responsibility of hospital administration. Hospital administration should ensure strict policies are followed or not. The transplant coordinator makes sure all the required documents are completed, and medical board must certify and sign a uh, brain death documentation. So all these steps should be followed. Ethical care is an important as important as clinical care. We should maintain a confidentiality of both donor and recipient. Communication with the family should be clear, compassionate, and honest. So, organ donation requires good coordination between the centers, where donor hospital and recipient designated transplant centers. So, these are the cold ischemic timelines for different organs. So, in source resource limited setting, there can be a delay in the confirming the brain death, and financial burden can be there. And finally, all this we have covered.